moving towards our next session. Vitamin D, along with calcium, may help decrease the risk of fracture in older adults. To discuss on this topic, Saga around vitamin D, we have our next eminent speaker with us, Dr. Mukut Ray, renowned endocrinologist in charge endocrine clinic, Tripura Medical College. And to chair this particular topic, I would like to invite Dr. Sanjay Sod, renowned diabetologist and endocrinologist attached with Konnagar Municipality Hospital. Along with them, I would like to invite Dr. Mridul Bera sir to please chair this session.
Vitamin D is an overhyped molecule or not, whether in every individual need an vitamin D. So, and when you take the vitamin D level, and every time we see there was some deficiency. So you need, every individual will need this vitamin D or not, and what is the relation between the chronic disease and the vitamin D level. So I think you will be the best person to talk in about 15 to 20 minutes.
Yes.
So just let's start.
Is it coming?
So I welcome Dr. Mukut Ray to deliver his talk on the saga of vitamin D. Dr. Roy is a DM endocrinologist and he is consultant at present and in charge of endocrine clinic, Tripura Medical College, Agartala. So over to Dr. Mukut Ray.
Thank you, Chairperson sir, for such a nice introduction of myself. And at the outset, I sincerely thank the organizers of HDS Con 2024 for inviting me to talk on this important topic, saga around vitamin D. And I also apologize for the initial technical glitch. So over a period of next 20 minutes, my talk will be focused on a few points where I'll be touching on the historical aspect of the vitamin D, and then we'll touch on the vitamin D physiology and diverse role. Where do we stand with the prevalence of the vitamin D deficiency, and what are the current perspectives, and we go with the take-home message. So if we start with the historical aspect of the vitamin D, probably it starts 750 million years ago, where it was seen that in a phytoplankton, Amelia Huxley was having a lot of amount of ergosterol, and probable reason for in the presence of this vitamin D in the phytoplankton was because of the early photosynthetic requirements of the sun exposure for their source. But having said that, the interest in the humans probably came in the 18th and 19th century before the industrial evolution. And that point of time, probably the rickets or the vitamin D deficiency was seen a disease of the affluent population because of the style of clothing, and most of the time they were staying in the indoors. And by the time when the industrial revolution came in the 19th century, the English disease typically known probably as later on the rickets, it came as with the features of enlargement of the long bones and the rib cage, curvature of the spine and the thighs and the short stature. Very soon, almost it spread in the Europe, UK and the USA, and almost 50% of the children probably was seen having the presence of rickets. But after some time, again in the US and the Europe, it was seen that if you expose your children for around 4 or 5 months in the outdoors, in the sunlight, probably these lesions healed, and there was search for what could be the source or what could be the causative factor for this disease, English disease and the rickets. And once it was isolated, very soon the fortification came and it became a rarity by next 30 or 40 years. And then in the year of 1928 or by 1935, when the 7-dehydrocholesterol was isolated, it got Nobel Prize for the same reason. And we could understand by after around 10 or 20 years that vitamin D is probably technically not a vitamin, and it is a pro-hormone, and which is produced photochemically in the skin from 7-dihydrocholesterol. What are the other vitamin D forms were isolated in the form of argocalciferol, cholecalciferol, calcidiol or the 25-hydroxy vitamin D, and then also we have got the calcitriol or the 125-hydroxy vitamin D, or the active form of the vitamin D. what is the vitamin D physiology and role in our body? So if we start with the source, definitely the 80 to 90% still should come from the sunshine. But having said that, you have to expose yourself in the typically in the mid-noon between 11 a.m. to 1 p.m. And probably if you continue for 5 to 10 minutes for 2 to 3 times a week, then it should give you enough amount of vitamin D. And the less 20% should come from the food, and which is very much important, like me, fish lovers, and then it should come from the fortified cereal and milk, egg yolks, and the liver, mushroom. But having said that, being the fish, probably the fatty fish and the sea fish are the important resources of the vitamin D. So if you go to the resources of the vitamin D, probably we have got less amount of the choice in the fatty fish, fish liver oil, than the liver, cheese, and the egg yolks. But if you go to the sunshine and the sun exposure again, we have to understand that probably the sun exposure is much, much more in the summer season. If you start from the April to the September, and again it become reduced in the winter season, where the important one, the ultraviolet B exposure, is very much important. And again, if you consider the spectra for the ultraviolet B radiation exposure and the synthesis of the vitamin D important for ours from the skin, then probably there is a very marginal overlap of the vitamin D synthesis with a lot of your exposure to the ultraviolet B radiation, and then once it is there, if you go further beyond, then probably there is skin erythema and some form of skin disease. So you have to wait regarding the your sunlight safety and also the vitamin D synthesis. So you know that the sunscreen prevents the vitamin D production in the skin, so you have to balance accordingly. Whatever may be the thing, or whatever may be the resource, maybe it is from the sunshine or from the sunlight or the sun exposure, or maybe from the food. But ultimately, once the 7-dehydrocholesterol is inside your body, then ultimately with the first hydroxylation occurs in the liver in the form of 25-hydroxylation, and then in the kidney with the 1-alpha hydroxylation, it goes to form the active form of the vitamin D, which is very much important for our calcium homeostasis, bone metabolism, and the neuromuscular function. Then also, if we go for the other pathways like 25-hydroxylation, then 1-alpha hydroxylation, and the vitamin D receptors, we understand the importance of the vitamin D deficiency rickets 1, 2, and the vitamin D resistant rickets. One of the important one is also your FGF23, which is important for your hypophosphatemia rickets. So we understand that there are classic roles for vitamin D, then also there are non-classic roles. Classic role is important for your calcium and phosphate homeostasis, and the non-classic roles has got plethora of the roles, starting from your cellular proliferation, differentiation, then immune function, and probably some important role in the cancer morbidity and the cancer mortality. And if you have got in the classic roles of the vitamin D deficiency, you know it starts from the children with the rickets, and in the adults going to the osteomalacia, and in the extreme elderly population going to the osteopenia and the osteoporosis. In a similar way, if you go to the extraskeletal effects, then probably it has got a role in the autoimmune and the infectious disease, some impact on the cardiorespiratory disease, then impaired muscle strength, obesity and diabetes, and probably there is some role in the cancer incidence and the mortality. And where do we stand with the vitamin D deficiency? Till 2023, we are classically diagnosing the vitamin D deficiency with the Endocrine Society guideline, where the deficiency was characterized as less than or equal to 20 nanogram per ml, insufficiency in the 21 to 29 nanogram per ml, and optimal is more than or equal to 30 nanogram per ml. Similar things were recorded in the Institute of Medicine role and the ASC guideline also. So if we follow this type of guidelines, probably the South Indian population have got a mean range of vitamin D is much more in comparison to the other side of the country. And probably it could be attributed because of the more exposure to the sunny weather in the South Indian population compared to the other parts of the India. This seminal study by the Maroa et al. Has shown that probably the eastern part of the country and the northeastern part of the country has got low exposure to the sunshine throughout the year if we compare to the other parts of the country. When the pan-India, approximately around 6 states were seen for the prevalence of the vitamin D, probably the Tamil Nadu again scored much more better in the vitamin D sufficiency. Assam did not score that low because it was in the 3rd position. So again, as we have discussed that vitamin D or the sun exposure is not that much in the northeastern region, probably there are some other factors like dietary factors are also important, which is why you could see that vitamin D status in the school children in the Assam is not that much if we compare with the vitamin D status in the Bengal, where the vitamin D deficiency is approximately 70% prevalent in this part of the country. So after knowing that vitamin D is rampantly deficient in our country, what we should go with the vitamin D supplementation? Does it have a role in this year of 2024? So the first review, systematic review, when it came in 2008, and probably before that, it was showing that vitamin D supplementation has got enormous role in reducing fall, fractures, bone loss in men and women more than 60 years. But then later on it was seen that there is sparse data on other age and other gender groups. You could not possibly to separate the effect of vitamin D from the calcium supplementation. Now it's difficult to identify specific blood level of 25-hydroxy vitamin D indicative of optimal health in all population subgroups. Very soon the second systematic review has seen that probably in the infant growth, there is not much of effect. Cardiovascular disease, not much of effect. Body weight, cancer, infectious disease, not much of effect. In pregnancy outcome, inadequate data. All-cause mortality, again, hypertension, inconsistent data. So very soon after 2008, if we go to the 2010, in the children and adolescents, even we have got a study from India by Khadilkar et al. Also, could not show not much of difference in the bone outcome in the vitamin D supplementations. When it was seen again in the 2014, in adults less than 50 years, bone outcome studies could not show significant difference at all. If it was seen in more than or equal to 50 years, again vitamin D supplementation could not prevent total fracture, hip fracture, non-vertebral fracture or vertebral fracture equally. And similar things were seen again in the pregnancy and the infant outcome study also. So what we could see at this point of time, where do we see the increasing relevance of the vitamin D deficiency? Probably you don't have enough data in the asymptomatic healthy individual if you want to go for the supplementation. Equally, you don't have enough data if you want to go for the asymptomatic individual, even at the high risk of the vitamin D deficiency. You have got some data where you want to give vitamin D supplementation in suspected osteomalacia, chronic widespread pain with osteomalacia, in cases of established rickets, or if there is any malabsorption syndrome leading to the other causes, or in cases of extreme elderly, in case of osteoporosis. So therefore, the Endocrine Society of India guideline in 2015 or the IOP guideline by in the 2017, they advised for 400 international unit per day to 600 to 800 international unit per day for the prevention of the vitamin D deficiency. But in this year of 2024, Endocrine Society guideline probably did not advise to go for the vitamin D, empiric vitamin D supplementation in the adolescent, adult, and in the age group from 19 to 74 years. So where is the importance of empiric vitamin D supplementation? You can see from this slide that in the infancy to 18 years of age, there is definite role for the empiric vitamin D supplementation. Then in the extreme elderly, in the ages more than or equal to 75 years, there is need for the empiric vitamin D supplementation. Pregnancy, there is a role for the vitamin D supplementation because it has been seen that probably if you give vitamin D supplementation, then it can lower the risk of preeclampsia, intrauterine mortality, and the preterm birth. And again in the pre-diabetes, it has been seen that In the pre-diabetes, if you give empiric vitamin D, probably it can lower the risk of progression to the overt diabetes in the long run. Friends and colleagues, we have to understand that this guideline has come from the United States of America. Probably that may not be relevant for our part of the country. And then the important thing is that Endocrine Society guideline this year has also suggest against routine vitamin D testing, routine 25-hydroxy vitamin D testing for generally healthy individuals who do not have otherwise established indication or established symptom. So we have to give a important choice that where we should do for the vitamin D testing. And at this point of time this year, probably we don't have a specific cutoff where we can understand that this is the cutoff for the vitamin D deficiency. Earlier, till 2023, we used to establish that vitamin D deficiency less than 20 nanogram per ml, but this year it has been abolished because there is insufficient data to see that this amount of vitamin D level can cause this amount of symptoms. So probably the current guidelines say that you can have the vitamin D testing where you can establish, you have got the evidence of established gastrointestinal malabsorption syndrome like the patient after bariatric surgery, celiac disease or the inflammatory bowel disease, or your patient is suffering from hypoparathyroidism, chronic kidney disease or the chronic liver disease, or having features of osteoporosis, osteopenia or the skeletal disorders. So if we go, probably we started as we discussed with the early 18th and the 19th century, we fortified vitamin D everywhere. We established and we could abolish rickets. And again now probably we are going back over. So are we over supplementing with the vitamin D? Are we doing over testing with the vitamin D? So having said that, probably OS test conquered and probably going over again. And we could also understand probably vitamin D supplementation is not a panacea, is not an elixir. But definitely we should believe that vitamin D should be taken from the good amount of food intake, that at least it should match the recommended dietary allowance or recommended daily allowance of 400 to 600 IU per day, and for the extreme elderly population, 800 IU per day. In our country, to conclude, we can understand that there is a paradox between the rural and the urban community. Friends, in the rural community, the sun exposure is abundant, but the food is deficient in vitamin D. While in the urban population, our children, they are having abundant vitamin D, probably from the food, but there is lack of sun exposure. Equally us also, where we don't have enough time for the exercise and going to the sun exposure for the morning walk in the preferred time of the vitamin D synthesis. So just following the Western guideline and just to conclude that vitamin D over supplementation has gone over, and before thinking and before going just like this, also for the prevention of the osteoporosis and the osteopenia, I think we should have our own guideline, we should have more data, and we should have more research to conclude that saga of vitamin D has come to a conclusion where probably there is not much role for supplementation, not much role for testing, and the question still remains in a debate. Thank you all for patient hearing.
Thank you very much, Dr. Rai. An excellent presentation and a really good compilation of the beautiful slide deck right from the 19th and the 20th century advertisements for the vitamin D supplementations. So now the forum is open for questions, if any.
Once a subject is vitamin D deficient and we treated him or her with oral vitamin D, maybe 60,000 weekly for 8 weeks, then how long we should give the maintenance one? Is it recommended about the maintenance or after treating the oral dose, loading dose?
before this guideline, before this 2024 guidelines, we used to follow that you give vitamin D of 60K for 8 weeks, then you follow with the 60K monthly for 6 months or like that. But at this point of time, we don't have this much of guideline because of lack of sufficient data. But again, having said that, I think in our country, we can follow the same one. But this year, this current guideline is saying that giving the higher doses like 60K weekly or 60K monthly should not be preferred. Ideally, we should go for the daily dosing, like 800 to 1000 unit per day. And the safe upper limit, as you know, it is 2000 IU per day. But many of the guidelines, like IOM guideline, they are telling that you can go up to 4000 IU per day, and the toxicity probably comes after 10,000 IU per day. So you have to individualize, you have to think.
Thank you.
One question. You see, we find patients many a times, those who are having a really low levels of vitamin D, even in single digits, like 8 or 9, something
Absolutely.
like that. So in those cases, we do find a few prescriptions where injectable formulations for supplementations are given. So what is your take on supplementation with a mega dose like 60K once a week, or maybe even higher than that, and the injectable preparation? So can you throw some light on this?
So because of want of time, I could not show you the slides. But having said that, if we compare with the higher doses of the vitamin D, and if we compare with the daily doses of the vitamin D, it was seen that if you continue with the higher doses of vitamin D, then probably there is increased incidences of fracture. And if you choose the injectable one, then probably at that point of time there is much more risk of hypercalciuria, and probably in the long run there is also risk of the renal stones also. So I would not go for the your injectable form of the vitamin D. If at all, as Dr. Hamadur was telling, that we can go for the weekly doses of the oral form of the vitamin D, if not the daily dose of the vitamin D.
Thank you very much.
Thank you, sir.
Thank you.
Thank you, Speaker. Thank you, Chairperson. It's time to facilitate our Speaker and Chairperson. I would like to Dr. Vivek Kumar to please felicitate them. Sir, please.